Welcome to episode 264, When Suicide Comes Up, Regulating Therapist Reactivity in High-Stakes Sessions with IFS, featuring Dr. Beth Mullen-Houser, licensed professional counselor, and Hanna Soumerai Rea, licensed independent clinical social worker. Make sure to subscribe to be alerted about future episodes. By Clearly Clinical. Learn, grow, shine.
Well, hello, everyone. I am here with Hanna Soumerai Rea. My name is Beth Mullen-Houser, and I'm so excited to be back on Clearly Clinical podcast. Today, Hanna and I are going to be talking about therapist reactions when clients are suicidal, and also weaving in the possibility of internal family systems, bringing skills to increase as therapists our compassionate and skillful clinical care with suicidal clients. So welcome. So Hanna, do you want to introduce yourself?
Yeah, I'll first just say I'm excited, even though this is a hard topic, I'm excited to, it's important. And so I feel really glad to talk about it. So I'm a clinical social worker. I work at Cambridge Health Alliance, Cambridge, Massachusetts, where I lead a IFS, Internal Family Systems service, and I've been involved in a fair amount of small but kind of growing studies at Cambridge Health Alliance, doing groups and individual sessions using IFS for folks with trauma. And in that setting, I certainly interact with a lot of people that have suicidal parts or parts that sort of want to give up. So it's an important topic. What else? Anything else I'm missing in terms of my background?
So I might throw in that you're a clinical lead of the PART studies, and those have been published. We can talk a little bit more about those later.
Yeah.
And also, I think Cambridge Health Alliance is really interesting in that it's community-based. My name is Beth Mullen-Houser again. I've presented a couple different episodes in the past, both of them involving internal family systems. And I'll say that I'm meeting with you on the unceded lands of the Ho-Chunk Nation, who have stewarded this time since time immemorial. And these lands are currently known in the larger world as La Crosse, Wisconsin. And I'm a clinical psychologist. My first training, which I'll maybe weave in a little bit, was acceptance and commitment therapy. I was trained in many different models, but that was my first modality. But I've been working with IFS, Internal Family Systems, for about 8 years now as my primary modality. And so today, as we talk about this topic, which I'm also know can be a heavy topic, but want to bring some hope into this as well. Hope that we as clinicians have a lot of skills and that we can really bring those skills to even very, very difficult situations. So really my goal for today, I'm going to quote Houston from 1990, whatever seems most likely to send you away more aware, more informed, skilled, and encouraged than you were when you came in. So that's our goal for today. So we're going to weave in some research that shows some of the reality of what can happen sometimes in the room with therapists when our clients are suicidal, and also weave in the real strengths that we have as clients. So today we are going to be talking about, again, therapist reactions to client suicidality. We're not going to be talking about what to do with the client very much. We might weave that in a little bit. And we're also not going to be talking then about suicidality interventions for the client, or what therapists can do if their client does commit suicide. Hanna, is there any sense, anything you want to flow in with around that?
Not really. No, not yet. But
okay, great.
Yeah. I love this general framing.
Right.
Yeah.
So I want to just frame our conversation, this conversation between Hanna and I. And actually, I'll stop and say Hanna and I have known each other now for over 2 years. We met when we were on a workshop together that we presented at the Internal Family Systems conference in Denver a couple years ago. And I've been really, really grateful to be working with her. I forgot to mention I'm also a research fellow now at Cambridge Health Alliance's Center for Mindfulness and Compassion, which is where Hanna works. So I'm really grateful to be involved with some internal family systems research. So Hanna and I, just our natural way of thinking about things now is through the internal family systems lens. So I'm going to talk a little bit about what this means. So for listeners who are familiar with mindfulness-based interventions for clients, including acceptance and commitment therapy and DBT, you'll already be familiar with some of these concepts. So in mindfulness-based therapies, we help clients to be able to notice in the moment when they're having an internal experience like distress or joy, but also to notice, importantly, that they can notice that experience. In the mindfulness-based therapies, that's often called the noticer self. And really key to this is that these other experiences that any of us might have, our distress, our joy, is not the totality of who we are. There's also that self that can notice any of our experiences. So, for example, our distress is not our entire internal experience. It's just a part of our experience. We also have a core self, as we call it in IFS, our noticer self that has capacities such as perspective, compassion, calm, and curiosity. So in IFS, we call those internal experiences that we know are just a part of us, parts. We call them parts of ourselves. And we notice that we may have many internal experiences that seem to be contradictory, like wanting to stay up later to watch that next episode of that show that we really like, but knowing that we're going to be really tired, we do that. And so knowing maybe that's not the best idea. So we have both of those experiences at the same time, and we might be able to even notice both of those. And that idea is time-tested, that we have different parts of ourselves. So as we go through this episode, you'll probably hear Hanna and I flowing between talking about client internal experiences, things like distress, and also therapist internal experiences like distress or anxiety or whatever. And we'll flow between talking about that as, like, for example, distress, or talking about parts of the therapist or parts of the client. I also want to just mention that as we talk, if we weave in some ideas, some experiences from clients or from consultees that we may have, because I think Hanna and I also both provide consultation to therapists around the internal family systems model, the identity of anyone that we talk about has been changed. So none of the names are the same, none of the identities. All right, Hanna, anything else you want to flow in with?
No, I mean, except that I do love the framing, your framing of like what IFS is and bringing in different modalities, because I do think that sometimes it can feel like this such a different thing. This IFS thing is so different, but really, I mean, even like wise mind, this concept of wise mind, knowing that we've got this emotional and this kind of rational mind is, and then this wise mind, right? This observing, this other is another model of that, I think is really helpful. So
absolutely. And we'll get into this later, but even the mechanisms by which IFS works have been studied and published, some initial, and they're very similar mechanisms as in other therapies. So
that's right.
Thank you. So I think the next thing I'm going to talk a little bit about is just, us as clinicians, us as therapists, and what is the likelihood that we're going to have a client express suicidality. So I want to just acknowledge that probably most of us have had this happen, and that this topic, again, is something that can bring up some concern for clients, for therapists. So I just want to really acknowledge that this is very common, that 63% of female clinicians reported having clients with non-fatal suicidal behavior. So this is, so not even talking about like they have attempted, but having, some ideation, some intent, really, really common. And that it's also something that can really bring up concern in therapists. So, one of those landmark studies back in 1993, Pope and Tabachnik surveyed 300 therapists and found that 97% listed significant fear of client suicide. So it's, if we experience some distress, like we'll be talking about when our clients express that they have some suicidal ideation or intent going on, of course we do. It's really common. So also, predicting and preventing suicide death remains pretty limited. Foxenall studied this in 2020. And we also know that the experience of suicide for clients can change really rapidly. So Coppersmith et al. In 2023 studied this and found that elevated suicidal ideation or desire could change to suicidal intent within hours or even just minutes, usually when they're not in the therapy room with us. So that time between desire and intent represents a potential window for intervention to reduce risk. And in response, researchers have been trying to find risk factors for it changing to that intent that are modifiable, something we can do something about to protect clients against suicidal death. So as therapists, we can't be there in the room with them when that's happening the vast majority of the time. We as therapists bring to our own selves and how we're able to choose really consciously what we do when we're with the client. So that's what we're going to be talking about today. Yeah. Hanna.
So one thing, there's so many important things here that are worth naming. There are experiences where it becomes really scary and risky and that, anyone, most people, when life gets really hard or scary or painful, or it's a common thing. It's a sort of it's a reaction that makes sense, that there'd be some part, using this model, that IFS model, that there'd be some part that would need an out or an exit. And so I guess I just want to say that unfortunately, I think because of some of our reaction in the field, it's almost like we hear less of it, probably than is out there. So I just want to highlight, I think that's important. And so anytime, when we lead these IFS groups or I'm sitting with someone, anytime someone mentions suicide, that's one of the first things I say is, oh, wow, so glad you named that, because sometimes and often it's just an important reality that we have inside of us.
And I wonder, Hanna, if I also hear you saying, part of what you're saying is that you are letting the client know that it's okay to talk about it.
That's right. That's right. And I'm saying I'm not alarmed. And especially if it's in a group setting, what happens is that someone will say something and then another person in the group goes, uh-oh, we're in dangerous territory. And so I want to signal to everybody, everyone's system, this is okay. We can do this. We can talk about this.
I love that. And as you are doing that, Hanna, what qualities in yourself do you have a sense you're bringing to that room?
Well, there's a few things. One, I'm not assuming. First thing, I'm not assuming that I know what someone means when they say they don't want to live anymore, or what's the point, right? That there's if we're coming at it with fear, then there's only one possibility, or there's only a few possibilities, which is we're in trouble, something bad's going to happen. Our vision gets very narrow. I mean, think about fight or flight response, right?
Within the therapist. I might have all those uh-oh. If I'm viewing it in a wider, more with perspective, the IFS, we'd say self has a perspective. It sort of has courage. It's curious. It's what is happening? That there's a million possibilities. It could actually be the beginning of some really important therapeutic change that leads to healing. Actually, leads to something positive. So I'm not assuming that it sort of reminds me of if you work with couples and a couple is are we just done? And if you can say, are we just done? That there could be some then new beginning. Yeah.
Does that make sense? So
that makes a lot of sense. So I hear you saying that as a therapist, you are, in that moment, you're bringing a lot of perspective, that this may not be what it sounds like at the outstart, but curiosity just to find out what is there.
Yeah.
And that has probably taken you some practice possibly, and I'm assuming for you, for me, I'll say for me, it took some practice.
Yeah, it takes some practice. Definitely. Yeah.
Yeah. And we've both learned some tools to be able to bring, to come into that sense of curiosity, of perspective, of calm, of kind of care and, and just holding space for that room.
Mm-hmm.
So I could use that as a space to transition a little bit to what the research has found about what can often happen with therapists in the therapy room when clients bring in suicidality. So first of all, I want to say that clearly clinical listeners are very curious, and I'm not assuming this about any one person at all, but just to bring in, a perspective of what can happen. So Jameson et al. Just in 2025 did some research that found that client expressions of suicidality do often prompt intense emotions in therapists. And Barzilay et al. In 2022 kind of found, kind of narrowed that in a little bit. The therapists can both experience increased distress and then also decreased emotion regulation, their own, when clients express suicidality, and that these emotional reactions can be things like fear, anger, hopelessness, and a sense of failure. So these intense experiences inside the therapist, which again, I just want to normalize. I think that in our training programs, we're not necessarily given a way to talk openly about what it can do for us if a client does this, if a client says that they have suicidality. So they've found then, they've looked at, does the therapeutic internal experience, the therapist parts that come up when a client expresses suicidality, does that affect the therapist's decisions about behavioral treatment for the client? And they found that indeed it does, that therapist treatment choices change when they're more dysregulated about their client's suicidality. So Barzilay, again, in 2021, found that when therapists were distressed and dysregulated around their own, inside themselves, they increased the recommended treatment intensity for the client, regardless of the client's level of suicidality. So it wasn't tracking what was actually going on for the client, but instead was in response to their own distress. And Knapp, Gottlieb, and Handelsman in 2024 also found that when therapists are distressed, they can choose not to work with suicidal clients at all. So I want to just mention that in Clearly Clinical episode 249 with me, I kind of walk through a lot about why therapists might do some harmful behaviors, and just bring a lot of care to the fact that this is really normal for us as therapists to have distress come up and that it might affect our own behavior.
Yeah, just to add here that just to kind of like highlight the distress and the normalizing that it's distressing when you hear like that someone is thinking about killing themselves. I mean, it's a very scary thing, and I just took, there's just this part of me that wants to say, like, I haven't had anyone end their life as a therapist, but I do live with the reality that it's very likely to happen given how much exposure I have to folks that have these kinds of fears or have these kinds of thoughts. And I hate living. I don't like that. It's a really uncomfortable, I don't want to ever have to go through that. So just to say that it's a really hard thing as a therapist to feel a sense of, there's a lot that goes into that, but like one other little thing that I remember as a trainee at Cambridge Health Alliance, every year there was some sort of suicide on our team. And those conversations after the suicide actually were some of the most meaningful experiences that I had as a trainee, because of how everyone really held the trainee or whoever it was having that, who had that experience. But really what we were doing in those moments were coming to terms with how much we can't control.
Mm-hmm.
Some of them live really scary lives, and it's just a really important thing, I think, to acknowledge what we can't control, and it's hard,
And to bring a lot of care to ourselves
yeah.
around that. Yeah.
Yeah, it's always scary to me. I just want to acknowledge,
Yeah.
even when I respond in a more calm way, I had a very recent experience, and as we were prepping for this, I was like, oh, great, we're prepping for this episode, and I will have had my first suicide now, because this is just because I had sat with someone who really sounded very serious about ending their life, and you know, and I definitely had parts that were like started to ask some of the risk assessment questions, and my client had said something like, "I'm not going to get myself sectioned," and I had to, that wasn't, just I had to sit with a whole lot of, this is not fun. I don't know what's going to happen, and in the end, they were saying the things that allowed me to feel like I didn't need to do anything. And then the next day they didn't show up somewhere that I thought they were going to show up to. So I thought, oh, and turns out they're okay. But anyway, it's
It's a
scary.
very real risk, and it is
It's a very
scary.
real risk. Yeah.
Yeah. So,
Yeah.
so just really to hold all the listeners in a lot of
Yeah.
care. This is
Yeah.
true.
Yeah.
Yeah. And then I'll talk a little bit about why it is important for us to sit with our own distress and to find ways ourselves to bring care internally in those moments, because it does actually affect client outcomes. If we as therapists bring a reactivity to the room when they express suicidality, if we are emotionally dysregulated, if we allow our distress to be there in a way that isn't helpful. So Michaud et al. In 2023 did a study and found that therapist reactivity, unhelpful reactivity to client suicidality, can actually result in increased suicidal behaviors. And Barzilay found that it's probably really due to this disruption of therapeutic alliance, right? If we're bringing our own distress, we're interrupting that connection with the client. And she found that the therapeutic alliance, or a reduction in it, was the reason why the clinician's negative emotional responses resulted in increased suicidal ideation in their clients a month later. That it mediated it, we call. It was what was going on. So as therapists, we know all about, like, I think clearly clinical people know about that therapeutic alliance, and that's the good news, is that that's really what we can keep tuning into. The other really interesting point of that is that the therapist's view of the alliance actually wasn't what was related to the client's suicidal ideation a month later. It was the client's view of the therapeutic alliance. So I want to give another shout out to another clearly clinical episode, 260, with Dr. Jordan Harris, on the need for feedback-informed treatment, so that we as therapists can be learning about our client's view of what's happening in the therapy room, to not assume that we know what's going on.
That makes me wonder, like, what was the therapist's view of what happened? Was it that they messed up, that they didn't do the right thing, or that they didn't ask more questions, or?
Well, it was probably the client reporting a disruption in the alliance that the therapist wasn't picking up on.
I mean, that was the client, but what was the therapist's view of themselves?
That's right.
I'm just so curious if they probably didn't pick, they probably weren't thinking that. They probably were thinking, what question did they not ask that could
either they weren't thinking it, or they weren't reporting it,
or they weren't reporting it.
In the study. But yeah, that's right. Yeah. So let's bring in a little bit of hope here. And I mentioned this in one of my past episodes, but there's really great. So Huggett et al. In 2022 found that helpful clinician behaviors are protective of client suicidal attempts. So what we do matters. It's really like when we can learn what to do that's helpful in ourselves, it's really helpful. And this is just another thing. Counselor increases in oxytocin in session predict better client outcomes. In this particular case from Fisher et al. In 2023, it was a reduction in depression, But those oxytocin levels mediate the relationship. The therapist's oxytocin levels in session mediate the relationship between client distress and their reduction in client depressive symptoms. So what's happening for us inside as therapists really can do a lot for the client, including helpful things to help the client improve. All right. Any other thoughts about that, Hanna?
Yeah, I mean, I guess, should we talk about some of those things that therapists can do to help in those moments?
Yeah, and I wonder if we could start with what therapists might experience on the inside. We've talked a little bit about it already.
Yeah. Okay.
But we call these therapist parts, right? So the idea is that when we all have a core self, that core noticer self that has this perspective, this calm, this compassion, this curiosity. This is our core self. But sometimes these other experiences that can come in and blend so that core self isn't as available in session. And that's probably what's harmful to clients. So Hanna, what do you notice, either in yourself or with people you've done consultation with, that can come in?
Yeah, I get heady. I can get problem solving. Oh, did I check off the box? Who should I call? What should I do? I have that urgency kind of thinking. I get scared. Yeah. I mean, I think that's, I get very agenda driven. There's this feeling of I need to do something. There's even this feeling of am I breaking the rules? I get into this place of I'm supposed to follow some kind of rule. Am I breaking the rules?
Yeah.
Or am I going to break the rules? It's this kind of, yeah. So those are some of the.
And I wonder in those moments, and I think I've experienced a lot of that as well, a lot of getting into my head and worry. In those moments, I'm probably not as attuned to the client.
Definitely. Yeah.
Yeah. I'm attuned to my own worry, my own concern, and not the client and what they're experiencing.
Absolutely. Yeah.
And including for myself, am I going to get sued by their family if they do follow through? So that risk management concern comes in. And I just want to say that that there is that is reality that can happen, and we are not going to talk about resources for that in the liability risk resources. But I want to point people into some wonderful resources. NAP et al. In 2024 has an article called Laws, Risk Management, and Ethical Principles when Working with Suicidal Patients in Professional Psychology Research and Practice. The American Association of Suicidality has good information about suicide risk factors, assessment, and interventions. And then also Deborah Pinal's who is a professor of psychiatry, law, and ethics at the University of Michigan, has a 2019 article on risk management called Liability and Patient Suicide. So we're not going to be talking about the liability piece itself, but instead what happens within us. And Hanna, I know that you have some things that you bring as a therapist in that moment or even earlier around risk management. And I wonder if some of that also helps you stay centered when a client has suicidality.
Yeah, I mean, I think that one, knowing what is comfortable for you or what is what your limits are as a therapist is important. And so for me, a limit I have is I'm not willing to break rules. I'm just not. My license is important to me. I'm not going to sort of have someone come to me and say, I'm going to do this, and this is my plan, and this is what I'm doing it, and I'm not going to just then say, okay, I'm not intervening, because I care about my license and my, it's important, myself, it's important, it's protective. And so, so when I meet with someone, especially if it's someone who has chronic suicidality, I'll say, I've been very clear about that, look, I realize that you have your own autonomy, that I cannot stop you if you were to decide to do something like that. That is the truth. You can, and if you tell me these things, I have no choice but to intervene in some way, because I need to protect myself. It's about one, I care. I mean, I don't only say it that way, but I do care about the person, but I'm not interested in taking over their autonomy. I don't think that goes so well. But I will say, yeah, this is a signal to me. If you share this with me, this is when I'm going to act. And these are the ways in which I'm going to act. And if you can engage at all with some kind of way of helping you be safe, even a little bit, I'm not going to act. Right. So, you could even say, that's another thing I think is really important, is like, there's a lot of things you can share with me. So it's not like, don't share suicidality at all. I want you to tell me, are you having thoughts? Even if you're having thoughts with plans, feel free to share it with me. But when you start to say, I'm going to do this on this date, or, then I really can't, then I need to do. So I don't, that's a long-winded way of saying it, but yeah. So I'm clear. I'm just clear with whoever I'm with around that. And it means that when it happens.
Yeah, that's right.
Yeah.
So you were bringing again that openness and like kind of a holding space so that they can explore all of that Walt Whitman, all the multitudes of experience they're having around ending their own life.
Right.
And knowing that the desire to end their own life is one strand of it in that moment, but that holding space that we can provide as therapists allows them to explore the other strands.
Right. Martha Sweezy also said to me once that I appreciated, you could always ask the person, is there any part that's worried that you're actually going to do something? And then talk to that one.
Yeah. So for the listeners who are not familiar with IFS, Martha Sweezy is an amazing individual who is a very wise, experienced clinician in IFS, was DBT, large in the DBT world before that, and has prolific with helping get books out around IFS, and is Hanna's mentor. That's right. Lucky Hanna.
Very, very lucky. Yes.
Yeah. Yeah. So that is,
yeah. So those are the things that I think, treating people with respect, letting them know that they've got some choices here they can share with me. And it's a very narrow, small, very few things that they would say that would lead me to do it.
Yes.
In terms of an intervention. And it's very clear to them.
And I hear that you help that clarity happen in the very first session.
I do. In the very first session, I'll let folks know. Yep. That these are the limits, and this is, and that it's, I had someone a couple years ago start with me that they said, look, I'm not going to work with anyone if I can't. I need you to know suicide's on the table. And I said, fine. And it worked out fine.
Yeah. Thank you for that. That's such wonderful guidance, wisdom, and your experience. And I hear too that, well, actually, I'll just reflect my own experience, that I know when I was a beginning clinician that I had a desire to not bring up suicidality that lived in me. We have to learn. I think I probably practiced with my classmates as a master's level, in my master's program, having that conversation. So I think we all do that as part of the intake process. But, this conversation on suicidality is a much more rich thing. It's throughout sessions with clients. And I know I would have, even then, especially earlier in my career, a desire to not talk about it, not go there. So that's one of those things that I think would happen inside me. I know sometimes there can also be that sense of, I care about the client. It's my responsibility to stop them. I'm bad if I don't stop them. Like I have to do everything I can to stop them. And that is something that's a very, very large responsibility. And Hanna, you've spoken about this really wisely before.
Well, as you're saying this, it speaks to this part of me that I have even when I'm saying to people, like, when you say these words, I have to section you. As long as you don't say these words, I don't. I have this part of me that feels like guilty, like, oh God, am I doing something wrong? Right. Like, should I not be saying, should I not be saying that? Is that a way of wink, wink, go for it? It's not. That's not. I'm just trying to.
And actually hasn't led to that for you.
It has
with your
not
clients.
It has not led to that. It's led to an increase in respect and care. And, I will say, after these experiences with people, usually there's a tightening or a closeness that happens, so yeah, it hasn't led to that,
It's
but
actually, it sounds like increased the therapeutic alliance.
it has increased the therapeutic alliance. Yeah, I have people say things to me like, I'm glad you're on my team, or like in a group a number of years ago, I've shared this, someone randomly said, oh, I'm thinking about, I got some bleach and I'm thinking about taking it. And I was like, oh God, what are we going to do? And then, so I think that there's something when people, I mean, we haven't really said this yet, when people share these things, there's a part looking for help. I mean, this
Mm-hmm.
is one of the reasons why it doesn't feel hard to not section, because as long as someone is help seeking, future oriented, you're okay, right? It's
Yeah.
even though it can shift. I want to go back to what you said before about how someone can shift really fast, from thinking about it to doing it. But still, I have to believe that if they're with you, talking to you, they're getting, hopefully, that's giving them a sense of I can go to someone with this stuff. There's some help available, or
And I wonder too, so when I have clients who have active suicidality, which is, I had this last week,
yeah,
if I can keep bringing my own sense of curiosity, of open-heartedness, just really being there with the client and welcoming whatever they might bring, it then I'm also able to, again, those multitudes within us, acknowledge that for the client. Just like you're saying, Hanna, we can acknowledge that to the client. So I'm hearing that both you have this impulse, this part of you that is bringing this idea of killing yourself, and you're also here in the room with me. And
yeah,
you're
that's
also
right.
telling me. So I'm sensing there's a part of you that doesn't want to do that. And that allows an opening of the conversation, right?
Right,
And
right.
yeah.
Well, and there's something, I think this is the piece where when we're triggered, we can't see anymore. We stop being curious. But if someone is in your office saying I'm suicidal, there's some big distress in there, usually.
Yeah.
Right. And so if we can say, I wonder if I sort of had a recent, sort of like, I wonder if we could bring a little relief. Like, is there a need for some relief? And could we see if we could help you get that right now? And there was this big worry, like, oh God, if I let you give me relief, then I won't kill myself. And that's a huge, I need to have that as a tool. And so we were like, okay, you can have that as a tool, as a possibility. Could it be not now? Like, could we see what happens now, but like hold on to that as a possibility? So I guess I'm saying all that because there's like a lot more possibility inside for negotiating, and like, and understanding, okay, it's not just, okay, we have to stop this person. It's, well, what's making it so that you feel like you have to end your life? Is there something we can do to help you feel a little relief? I don't know.
And I wonder if some of that, well, I won't say I wonder, in my
Yeah.
experience with my clients, when we have that kind of open hearted conversation with my
Yeah.
heart there, extending to them, and also just curiosity, it seems to increase the client's observer perspective of their suicidality.
Yeah.
And in so I'll talk a little more about IFS here in a minute, but in IFS, the way we would understand it is that when clients do those behaviors to take their own life, they are like fully inside their, from an ACT perspective, they're fused with that sense of wanting to kill themselves. They don't have a perspective on the parts of themselves that don't want to. So if we can increase their ability to notice that, then in that moment when they're not with us, they may be able to draw on that. And in fact, I've had clients tell me I really had suicidal intent starting to creep in, and I even thought about reaching for the XYZ. And I said, well, okay, so in that moment, why didn't you? And they'll say, well, I guess I'm able now to recognize that that's actually happening. I can notice it. Like I can see that that's what was happening. So I think as therapists, that ability in us to bring our own warmth, our own curiosity, that holding space so they can notice their own experience can be really protective.
Right. Yes, I love that. There's also just something about like when there's a crisis inside, and I started to talk about this, I think, sort of before. There's like a whole other possibility that crisis is often when things are willing to change, when we're willing to change. And so it's just, going back to this idea of hope, that when someone's suicidal, this is something that Martha, I think, had said, Martha Sweezy, in our podcast that we do together.
System Updates, by the way, it's a fantastic
System
podcast.
Updates, great. Yes, listen, go ahead. But she had said something. We were talking, I think, about sort of some suicidal stuff, and she had said something like, what's the difference? If you're looking up at the sky and you're like, there's like, what's the point of life in this like deep dark, why am I here, this is awful, versus looking at the stars and going, what's the point,
With curiosity.
It's like it's with curiosity, it's with warmth, it's with resource, it's with this internal resource, like, what is the point of this big world that we live in,
Mm-hmm.
So yeah, we don't want to get rid of that voice, just give it a little resource.
Beautiful. I love that. So I think I'm going to make sure we transition in just a moment to, well, as therapists, number one, in the moment, in the session, how do we recognize that our own experiences, even as a client is telling us about their own suicidality, it's almost this dual awareness as therapists of the client's experience and our own experience. And the way that Hanna and I tend to think about this is from an internal family systems perspective. So I want to just take a moment here to talk a little bit about IFS. So IFS is at its heart a method to create internal attachment bonds between our own compassionate noticer self and any other of our experience. IFS has an emerging evidence base with small randomized clinical trials, quasi-experimental single-arm studies, and pilot studies. It does have peer-reviewed published studies, including client concerns such as depression, PTSD, rheumatoid arthritis, substance use, other addiction. And it's been found in the study that Hanna's the clinical lead for that does that it has high participant satisfaction and strong attendance. So Delara Ali et al. In 2025, on a paper including Hanna, found that after 3 months of therapy, participants rated the IFS intervention as 92% of them willingness to refer a friend. Like, that's a really high rating of liking that therapy model. And also retaining 70% of participants after 3 months of therapy. And that's it's not your like sterile research. Like, they haven't excluded everyone, right? This is in the
That's
people
right.
who are in the trenches with the hard stuff. So that's actually quite a good retention rate of IFS.
Yeah. I think that's and maybe it does speak a little bit to this idea of we're not so fearful. And again, I know other models do this really well, but there's I remember sitting in some of these researched groups where people bring up suicide, and our response is, okay, there's a part that's got this suicidal idea, and there's a lot of, I think, people just kind of relax. There's a feeling like, oh wow, I can bring this here. This is okay here. We're not gonna, because, well, there are a lot of really good models that know how to do this too. More often, many of us are trained to get pre-scared and to respond in more of a controlled way. And the whole group could have easily looked and went, oh God, something bad happened. Oh God, someone's gonna, whatever. And we can respond
in that
differently.
moment, the therapeutic alliance is not as strong. If we come in a controlled way.
Definitely the therapeutic, it's not as strong. They also feel disempowered. They feel like it brings up a whole lot of stuff around. And if you're, a member of a marginalized group, feeling like someone's going to come and get you or take you, or it can cause such big rupture when we do that. And
That's right.
especially along race lines and along
Yeah.
socioeconomic, around, these people that are going to come and, this like, or
Yeah.
take your autonomy, or
And
that
maybe reality.
we don't want it. Yeah. We do not want to be the face of that as a
That's right.
therapist. Yeah.
That's right. That's right.
Yeah.
So the experience again with these clients who have a lot, they're bringing a lot to their sessions of their lives being pretty challenging, is that they like it enough to refer to a friend, and they stay.
And they stay, and we have very deep, dark, hard topics with a lightness and a buoyancy.
Yeah.
That's what I would say.
Playfulness
IFS does that. Playfulness. Yeah.
Another one
like
of the
that there's fun.
self qualities.
That's right. Yeah. It can be fun. Yeah.
So to just give a little more background on IFS research, a really cool thing that also happened as part of the Cambridge Health Alliance Center for Mindfulness and Compassion Studies is that they have started to look at the mechanisms by which IFS works, because I think that, Hanna, as you alluded to earlier, when people first hear about IFS and this idea of parts inside of us, it can seem really woo-woo and really strange. Yeah. And like, well, how could you ever prove that that happens? Well, so what they've done is they've looked for mechanisms that are being used with other therapies that have found, to be useful for other therapies. Let's talk a little bit about what therapists can do when first of all, how we notice our own experience in session. We hear a client say, yeah, I'm thinking about killing myself. So both we need to be attending to what the client's saying, but we also need to notice what's going on inside ourselves. So I do talk about this in my other two episodes on Clearly Clinical, but Hanna, I want to hear how you do this. How do you notice in the moment your own experience?
So I'm going to steal again from a Martha Sweezy. Going to give her credit here that in my earlier training, she said, which I found so helpful, to really anytime someone does or says something that is hard, or might be hard for us to hold our seat, or they seem really dysregulated and all that I will intentionally slow my volume down, or just slow myself down. I lower my voice. I might even, as someone's talking, like get my voice in there just to stop the talking for a moment and then pause and then talk again. I'm literally slowing everything down. And when I honestly, also when I lower my voice, I'm feeling more calm myself. Like it does something to my nervous system. I have fillers. I have literal like things I'll say like, oh wow, this is really important. Let's slow this down.
Which it is.
Which it is.
So
right. Like, wow, we really let's really take a moment here, or, I have my own little mantras I'll say inside, like and I'll, in a group space when things kind of get messy, I'll say, there's, nothing we can't be with here. That I stole from my own therapist. Thank you. But, there's nothing we can't be here that we can, I'm just kind of in a way I'm telling the client that, I'm telling my own nervous system that like, whatever comes up here right now, we're going to kind of work through this together.
Beautiful. So you noticed like the pace of your own voice.
Big time.
You kind of noticed a behavioral thing, and that's maybe somewhat easy to notice in the moment. And then you change that, you slow it down, which actually literally changes what's happening in you and probably what's happening for the client.
Right. Right. And just to remind yourself that like, just because something got said that was scary, like the person's still talking to you. You have like a whole session usually. And if you need another hour, you make another hour, right? If someone's starting to talk about suicide, there's no like lion in front of you right there, right? That you can slow it down. It's okay.
Yeah. Beautiful.
Yeah.
And I know that when I first started learning IFS as a model, I had a little bit of this in grad school, but not since. I didn't have much invitation to notice what was happening for me inside in all of the training I had gotten. And so for a while, what I did was I put a Post-it note on my computer with a heart that reminded me to look in my own heart. And in IFS trainings, so IFS Level 1 training through the IFS Institute and its partner, Cambridge Health Alliance, Center for Mindfulness and Compassion, one of those things that we do is we have practice sessions of practicing IFS. And we, in those triads, those practice sessions, the IFS trained person who's there, the program assistant, stops the person who is in the therapist role every so often and says, what are you noticing right now about yourself? And so it's literally learning a new habit. And so I had that Post-it note on my screen to remind me to stop and look inside, to take a moment. And I still do that. In my 8 years of doing IFS with clients now, it has become much more of a habit. But I still regularly, especially when something really big is happening, I will say to the client, I'm going to take just a moment and just get clear about what I'm sensing here. And I will go inside and just check and make sure, see what's coming up inside me, and I will notice sometimes one of my big tells for that it's not my open-hearted curiosity is I feel an agenda coming in and I feel a sense of urgency, which I think would make so much sense when a client tells us they're suicidal. And I know that sense of urgency, if I'm talking out of that, I'm going to talk fast. I'm not going to be attuned to the client, and that's going to impact our relationship. So I think I hear when Hanna, what you're saying too, is that slowing down really allows that attunement.
Yeah, right. When we're in crisis or when there's something scary happening, that is the time to slow way down. And so we say that to our own systems, we say that to our clients. It's a really important learning for them too. It's a modeling something really important, right? Because we're unblending from our own parts, then we help them. They're unblending from they're sort of getting to see what's happening. They're much less light. I mean, that's the anti, quick movement towards suicide, right? It's like helping people notice a part. You're much less likely to have an impulsive one step in and move towards acting fast if they can learn to slow down. So I also think like doing this, practicing or being with parts or being with whatever it is that comes up for people around suicide outside of sessions is important. And so just like I have just come to terms, and it's a hard thing to come to terms with, but I've come to terms with the fact that my clients could do this. And I don't want them to, but they might. And
I wonder if you have parts, right, that have, like you were describing that in the beginning of today, actually, your own internal experiences that come up around that, your own distress, your own sadness, fear. And those we might think of as parts of us. And when you come to terms with it, I wonder what you are doing with those parts of yourself.
Yeah, I guess caring about it and deciding that I'm going to be a therapist anyway. I don't know if that's like, it's a radical, in DBT, it's radical acceptance. It's just like, I made a decision not to do a wellness check the other day because I knew that it wasn't the right thing for the person. And I was like, okay, what are the risks? There's this risk over here. And then there's this risk over, one risk is I lose the relationship and, but then maybe there's a chance I save this person's life. I mean, probably not. And based on where things were left, it didn't make sense. In the long run, it was not the right choice. So I didn't do it. I didn't do a wellness check in this case.
It sounds like in that moment, you were attuned to the client and what they were giving you and making that choice. You were kind of holding your own fear.
Yeah, that's right.
Those parts of you that had that fear in that moment, and you were tuning to the client and making a decision based on the client's needs.
That's right. And what was in my integrity too, as a human, like it felt like it was more in line with my integrity to not react.
Yep.
And I took care of myself by having talking to a medical director and having a consultation and documenting it. That was the right thing to do. And then I ended up with a a phone call with a thanks, I'm glad you're on my team. So,
Beautiful.
that was a better choice, I think. But
Yeah.
but I was accepting that I could have lost my client, and that is there's no way to avoid that, really.
You were making a risk assessment.
I was making a risk assessment.
And that maybe actually in that moment, attuning to the client and increasing that bond was actually the most protective.
In terms of the risk. That's right.
Yeah.
Because we don't know the realities, right? We can't know what's happening in someone's mind always, or their outside of session. We don't know,
Yeah. But it took you noticing your own fear and your own, right, some other urges you might have inside to do something else that might be more controlling. So I want to just talk a little bit now about a couple cool research things around therapists learning about their own experience, because there's ideas of what we can do in session, but as therapists, it's actually really important for us to learn about our own systems, our own emotions, our own thoughts, and to do that outside of session too. So Asan et al. In 2022 did a study of a meditation intervention for healthcare providers. And they found that intervention resulted in improved, the healthcare providers had an improved ability to manage their personal vulnerability. So kind of like what you're describing. It's a vulnerable place as therapists. It
is. It's
to really
vulnerable.
To sit compassion and to not just go, this is what we're going to do now. We're going to section you. And that their own knowing, their own experiences better resulted in improved managing of their personal vulnerability, including their own feelings of inadequacy. The healthcare providers being better at setting clearer boundaries and practicing self-care and more acceptance of situations others and themselves. So healthcare providers, therapists learning about our own, having mindful awareness of our own experiences results in our own improved behaviors, and possibly even, some other research, Barzilay has shown improved ability for clients to be safe. So another really neat thing, if we look at it from an IFS perspective, I brought in how IFS training actually helps to establish this habit of checking with our own internal experiences. So clinical training as therapists in IFS. And Carl Moda and colleagues in 2014 did a qualitative study of 7 counselors who took a 3-credit master's program course on IFS. And what these therapists reported was that as a result of this IFS training, they had an improved ability to identify their own internal processes in session, including personal agendas for the clients, which are not necessarily based on the client's needs, but in their own. Had a better ability themselves to have tools to manage their own internal processes and to bring those tools to the client, and to help the therapists identify for themselves when their own internal experiences were hindering therapy. And what they report, this is not from the client's perspective, but what the therapists report seeing in their clients is that there was an enhanced therapeutic relationship with their own clients, that the clients had increased awareness of their own internal experiences, and the clients had an increased ability to model self-awareness. And that, they were able to model as well, the therapist could model that self-awareness for their clients. So it's just, I just encourage anyone listening to look into whatever way makes most sense to you. Hanna and I both found IFS training to be effective for this. There's my evidence that mindfulness-based training can also bring some of these skills in as a way to know our own experiences and make a conscious choice, that values-based decision in the moment about what we're going to do with our clients. Yeah. Hanna, is there anything that arises for you with that?
Sort of sitting with this feeling, what's, all the just what a wonderful thing that can arise. It's like when our parts in the IFS model, when our parts step back and let us present with people in these incredibly vulnerable moments, that there's so much possibility with them. And so I guess I want to say that, maybe end with that, and I think the more space I've gotten from those parts that get scared, first what came was acknowledging to the client, I am limited in my control. I just sort of letting them know I get that they have autonomy. But then what comes with that after is, and I care about you. Just that's another, and I don't know, would I say that to everybody? I don't know what I would say to everyone, but there's like I don't know, there's an ability then to be human, right? That like, with people in those moments, like when you can accept in a way that you're not actually in control, that you could be present and then you can also be human. And I think that is probably a more powerful intervention.
Absolutely.
In a moment when someone's questioning whether they want to live.
In the moment, absolutely. Oh, Hanna, thank you. That is a wonderful way to wrap this up. So there you have it. Some ideas from IFS about ways that we can interact with our own internal experience so that we have the power as therapists to consciously choose to keep connecting with our clients and to make those treatment decisions that are based on the client's needs and not based on our own distress. And I just really, really appreciate that wisdom that you bring, Hanna. So I guess to wrap it up here, Hanna, is there anything else you wanted to add, or should we start with how people can find us?
No, I think that's it. I so appreciate having this conversation with you. You bring so much to it. So I hadn't thought about so many of the things that you bring up around, even just the research around connection and the importance of connection as a risk, as a variable,
And I feel like you do that really naturally in your sessions. I so appreciate all of your wisdom, both clinically and research-wise. So thank you for being here with us. And so, Hanna, can you tell us, where can we find you if people want to learn more about you?
So let's see, hannarey.com, I think is that right?
And Rea is REA.
REA, yep. Oh yeah, hannarey.com. I'm like, well, should I double check that that's right? How funny.
I could probably pull you up.
That's okay. So that's my website. You can find me there, and there's some more stuff about me there. Also, as I said before, I do this podcast with Martha Sweezy and Fiona Kate Rice called System Updates IFS Chit Chat, and that's a lot of fun. We have a lot of fun talking through IFS concepts. I think that's...
And that can be found in all the normal places.
That can be found in all the normal places. I think that's about it. Yeah, I'm at Cambridge Health Alliance, but, Yeah.
So, and I'm, again, Beth Mullen-Houser. I can be found at selfleadershipjourneys.com. Or if you Google Beth Mullen-Houser, there's not many of us, so I pull me up. I want to also shout out that another thing that Hanna and I do together is we sort of take turns leading the Parts meditation, which is a free 15-minute weekly Zoom IFS meditation through the Center for Mindfulness and Compassion, which you can find at www.chacmc.org/connect. Lots of great things there. And also, I have a Spotify IFS Vibes.
And Diane Joss, did we mention her as
I did not mention her.
Figure,
Thank you.
Kind of leading a bunch of IFS research related to suicide. So
yes, which I'm working with her on. Yes,
Great.
Diane is leading this, and she's amazing.
Yeah,
and you will have the ability to hear directly from her at the IFS conference.
Yes, that's right. Good.
All right. Well, thank you so much, Hanna.
Thank you.
And everyone, take good care, and thank you for spending this time with us. Okay. Bye-bye. Oh.
You've just finished listening to another exclusive Continuing Ed podcast by Clearly Clinical. If you like what you just heard and you need Continuing Ed credits, please visit us at clearlyclinical.com to check out our 1-year membership, where you'll have access to our growing library of Continuing Ed podcast courses. Clearly Clinical, where our goal is to help you learn, grow, and shine.